Good morning, colleagues. I hope it's a beautiful morning for everybody and Happy New Year. Songok, are we good to start?
Yes, Doc. I guess we can start as the rest of the members join us, because I know we may not be having time. Some members in the call are also joining other calls in between. So I'm thinking we can start off. Yeah.
All right, so thank you, Songok, and Happy New Year once again, everybody. Welcome to today's webinar, and we are happy with the attendance, and it's just a good way to kickstart the year, just knowing that, first of all, we are grateful to God for the opportunity that we are alive and we are here today. Putting into consideration the fact that we have a lot on our plates, and there's a lot that we are still supposed to do to just ensure that we are able to monitor the HIV epidemic for the country. So we have several of us who have been able to join. So far we are at 102 participants who have been able to join. We're also happy that we have colleagues who have managed to join from the counties, our implementing partners, our county AIDS coordinators, CHRIOs from the counties. We appreciate. We also want to appreciate that we have participants who have been able to join from PEPFAR, our ESG partners, and also our partners supporting at national level, the Palladium team, as well as the team from NASCOP. We want to appreciate you all for taking time to join this meeting. So as we start, I would request that we start with a word of prayer, and I'll request Dr. Winnie Nyanya to please pray for us, then we start the meeting. Dr. Nyanya, if you can hear me, please pray for us.
Good morning. I can hear Doc. Let's believe in heaven. Thank you this wonderful. As we call you, we ask you to be with us meeting, passing our daily burden, so that whatever person is going to us taking care of patients. We pray this in Jesus' name. Amen.
Amen. Thank you, Winnie. Can you hear me now?
Yes, we can hear you, Doc.
All right. Thank you very much. Faith, our co-host, can you hear us?
Yes, definitely I can hear you.
Her net is a little bit okay. So welcome everybody. We will be joined by our new head NASCOP later on in the meeting. She was to give her remarks at the beginning of this meeting, but she has been called to another assignment just now. And we know that before the meeting comes to an end, she'll be able to join us, and we'll appreciate that. At this particular point, I would just like, first of all, to encourage us to, in terms of that we introduce ourselves on the chat, because we are many, we are more than 100 participants. So for all the participants, kindly utilize the chat to introduce yourself. I know Franklin will share the format of how you just introduce yourself, but basically we just need to know your name and the organization where you work. So kindly utilize the chat for the purpose of introduction. I know you had also introduced yourself as you're logging in, but just for the sake of maybe the rest of the participants knowing who is on the call, please, you can do that on the chat box. I would also like to take this opportunity to welcome our colleagues for very quick opening remarks. I can see that we have from NASCOP, we have the care and treatment manager, the care and treatment team who have been able to join. We have the counterpart of for care and treatment, Dr. Masamaru, welcome. We're happy to have you on board. So we'll have some remarks from your end. I cannot see USID. and DOD, but I think we will just give an opportunity to the team that is here for just very quick opening remarks. And then I also want to really appreciate the Palladium team. So I know Dr. Jacob is on the call. We'll also have maybe just 1 minute, just say hi so that we don't take a lot of time when it comes to remarks. So I'll start with Dr. Masamaro, then Dr. Jacob, and then we'll finish with Dr. Momanyi. Very brief, like 1 minute or less than a minute each, so that we can move to the agenda. Dr. Masamaro.
Yeah, so thank you very much, Dr. Ramisi, and Happy New Year to everyone. We are pleased to be participating in this webinar. From CDC and generally from PEPFAR side, continuity of treatment and retention remains a key priority for the treatment program. From the data that we have seen, we have generally done well as a country, but there are definitely opportunities to improve, looking and ensuring that our cohort of patients remain and are engaged on treatment. Of course, the bigger question is, for the gaps that remain, how do we truly identify, those who eventually end up disengaged on treatment? And I think, these are the discussions that we would like to see and propose a way forward. Also, in addition, we are also quite keen on ensuring that the vaccine coverage for COVID-19, especially amongst PLHIV, continues to improve. I think the preliminary data that we have is still quite low. So we are happy to have thoughts, to have discussions, and to have a way forward to ensure that at least our PLHIVs are vaccinated. But really glad, and on behalf of CDC and the treatment program, happy to be part of this process and look forward to the engaging discussions. Thank you.
Thank you, Dr. Masamaro. Very brief, to the point, and very clear, just reminding us how we need to close that gap. Thank you very much. I'll now welcome Dr. Jacob. And as Dr. Jacob is sharing, Songok, you can just project the agenda. Just project it. We don't have, because it's a very brief agenda. Just project it, because we know that we'll be on this call for at least 2 hours and should be done. So Songok, just share the agenda. Project it as we continue with the remarks. Dr. Jacob.
Yes, good morning, everyone, and welcome to the session. I just want to appreciate NASCOP for convening this meeting. I think it's always exciting to have, a team of data, HIS and program people, join hands in addressing gaps in the program and to support any program improvement work. So we are very excited and are looking forward to a very productive session today. Thank you very much.
Thank you, Dr. We appreciate the support from Palladium. I'm happy that now we have the CDC representative. Disha had not joined earlier. That's why we had skipped that part. But Disha, welcome. Please just give us less than a minute remarks so that we can be able to proceed, and welcome to the call. Disha.
Good morning, Dr. Ramisi, and good morning, everyone. Thank you for joining the call, and we're happy to have everyone on the call. As I think everyone has said, this, whatever we're doing here has been very key, especially just reflecting what is coming up in the COP. We have so much work to do, and we're depending so much on the individual level data to be able to start to tell a story about the epidemic in Kenya. So I'm happy that we are doing this using the individual level data, and I hope that even as we orient the IPs, we'll see more IPs using their data. The data that is in the warehouse is for you guys to use, is for you to be able to track your patients, to know how they're doing with their treatment. And we want to see more traffic into the warehouse. We want to see more people reporting. We want to see all, if not, we want to actually get to 100% reporting rate. just so that we have data that can tell a story, data that can build up on what we are seeing from the individual, from the aggregate numbers that we have from DATIM and DHIS2. So welcome to the webinar. We look forward to hearing more from you. Please give us your feedback. Tell us how we can, support you to even do better with your sites. Thank you, and back to you, Dr. Ramisi.
Thank you, Ndisha. Indeed, we are very happy and grateful that we have that support and that we all have the same objectives and goal set in terms of what we want to achieve for the country. Thanks, Ndisha, for that. I'll now invite the Care and Treatment Manager, NASCOP, Dr. Lazarus Momanyi, for some remarks. As Songox continues to scroll on the program for today. Songox, you can scroll up. We will go through the objectives, but you can just scroll up because it's a very, thank you, you can leave it there. That's the agenda. So Dr. Momanyi, welcome.
Thank you, Violet, and Happy New Year to everyone. I think mine will also be very brief because we will have more discussions as we go on with the webinar. One is just to point out that we currently have over 1.2 million patients on treatment. And if you note that from what you'll see from some of the presentations we make is that we have over 80%, almost 80% of these clients, their data is available in the National Data Warehouse. So mine is just really to request for all of us to work together to ensure that the patient level data that we have in the National Data Warehouse is data that is reliable, is complete, is accurate, that we can be able to actually do all kinds of analysis. We're able to do analysis on patient outcomes, viral load suppression, retention, even various aspects of service delivery, including differentiated service delivery, models these patients are on, and many other analysis. So I think really for us as we begin the year is just to ask all of us to embrace. We need the support of everyone to ensure that the data we have is data that we can use and make sense. And most importantly, I think last year we had a lot of challenges in terms of commodities and viral load for our patients. And with some of the measures that have been put in place, we hope that this year we'll actually be able to overcome some of those challenges so that then we can be able to analyze and use data for decision making that is reliable and can also help us to improve service delivery and the quality of care that we provide to our patients. So thank you so much, and welcome to the webinar. Thank you.
You, Dr. Momanyi, and colleagues, as you continue joining, because now when we started, we were around 100 participants, and right now I can see we are about 180 participants, meaning that about 80 of us were not able to hear the earlier parts of the webinar. But we are happy that you have been able to join. We just wanted to let you know that Head NASCOP will be joining us later on. We have Dr. Rose Wafula as our new Head NASCOP, and she will give the remarks towards the end of the meeting. So as you can quickly see in the agenda, I requested Songok to project it. That will be the agenda for today. So it's a fairly brief session that ends at 10. And we started at 10 minutes past 8, so it's already 8:23. We should be in the next session where we'll go through the reporting rates of stale databases, and also session 2 where we'll be tracking the HIV treatment outcome, and session 3 where we'll be looking at COVID-19 module. I think for me as Violet, mine would be to also take us through the objectives. So we can project the objectives for this particular session, and to just welcome you back on board this 2022, Happy New Year 2022, and to tell us that, welcome back. There's a lot that has been planned for us to be able to do together as we work towards ensuring that specifically the rich data that we currently have as a country in the National Data Warehouse, as we have been sharing earlier, that 75% of our clients who are currently on treatment, at least we are able to collect their data in the electronic databases, which is really good for us. Apologies for that. I don't know if you can hear me. I'm using my phone. And can you hear me?
Yes, you can hear you.
Yeah, sorry about that. So today we just want to be able to know the current reporting rates in the National Data Warehouse, as we also get to understand what is the impact of us uploading stale databases when we are tracking the treatment cohort. What is the impact of that? And I think as we'll be going through the slides, because we know some of us are fairly new, we'll also help you understand what's a stale database, so that you understand that if you upload data at a certain or at a particular time period, then it's called a stale database. So we'll also be able to help you understand that. We also want to be able to understand the treatment outcomes of patients that are currently on treatment as at 30th September 2021. So this is by 30th November 2021. We want to just be able to understand that particular treatment cohort, and also be able to understand what are the programmatic related issues that are affecting our ITT. And this is really important for all of us to be able to understand, as well as knowing that we already have a COVID-19 vaccination module in Kenya EMR. How do we utilize that module and ensure that the uptake is optimum based on the current situation that we are at? Remember that we are handling a double epidemic as a country, or double pandemic as a country, and this is really important for us to just make sure that we are able to monitor, especially for the HIV positive clients, ensuring that they also uptake the COVID vaccine. So this is also an area that is important to us. So at this particular juncture, I would like to hand it over to Franklin Songok to take it up from here. And we will be three moderators. There'll be myself, there's Faith Ngare, and there's Franklin Songok. And I know we have many other things. So in case one drops off, we will alert you, but we are here available to just make sure that the meeting runs smoothly. And in case of any hitches, we will be able to resolve it in a timely fashion. Songok, over to you, and karibuni sana, and Happy New Year.
Thank you. Thank you very much, Dr. Ramisi, for starting us off. So I'll take you through the first session, majorly focusing on reporting rates and just helping us be able to understand what we mean by uploading a stale database and what are the potential effects, or what is the impact of us uploading a stale database to the National Data Warehouse. So let me stop sharing the agenda, and then share the slides. Just give me a minute. Okay. Yeah, kindly confirm if you can see my screen. I need to put this on full screen.
Yes, Songok, we can see your screen. Just put it in presentation mode. Thanks.
Hey, okay. Yeah, hope you can now see my screen on presentation mode. Faith, confirm?
Yes, we are good to go.
Thank you. All right, thank you. Yeah, so I don't want to go through these other preliminaries. I think Dr. Ramis has already mentioned those are the sessions that we will be able to cover today. So we'll cover session 1, which focuses on reporting rates, and then session 2, which will focus on tracking HIV treatment cohort. Then we will go through the COVID-19 vaccination module, which is a new module in Kenya EMR. So yeah, so I'll begin from here. And so just to start us off, I think it's just good for us to just be able to appreciate the fact that we've made a lot of improvement in as far as uploading or submitting our data to the National Data Warehouse is concerned, though we've not been steadily improving, as you can see from the graph that is projected. We've not been very consistent, so we've been flip-flopping kinda. So it's for us to really encourage the county teams, our implementing partners, to be able to ensure that all our sites or all facilities that have EMR are able to upload their data to the National Data Warehouse. I think that is our beginning point, and this basically refers to our denominator in this case is all the sites that have EMR, and our numerator is the sites that are able to upload their data to the National Data Warehouse at each one given time. And here we are looking at a month, that is from the first day of the month to the end of the month. So as at December, that was our reporting rate. I think we were at about 80%, and November we were at 75%. And I think for those who've been following this, remember in around 2019, when we started uploading our data to the National Data Warehouse, we started with a low of about, I think it was about 39%. So there've been a lot of improvement, but we still want to encourage our stakeholders to ensure that all sites that are using EMR are able to upload their data to the National Data Warehouse. In case the sites are having any challenges, our colleagues in the facilities are having any challenges, you can always reach out to us so that we can support and ensure that all sites are able to upload their data. We would really wish to see 100%, and that would also help us push the number of patients currently on treatment being reported and followed up in Kenya EMR, and also their data available in the National Data Warehouse. Because as Dr. Momanyi has mentioned, we want to push that to around 90% thereabout, if we are able to ensure that all the EMR sites upload their data to the National Data Warehouse. So let's then dive down and look at out of the total number of sites, and here we're looking at about 1,477 care treatment sites out of about 3,500 plus. But again, we know very well that not all the 3,500 have EMR, but there's still a good number of sites that have EMR, but they're not uploading based on the reporting rates that you've seen. So this is how the counties are performing, and we really need to applaud counties that have been able to ensure that all their sites are uploading their data to the National Data Warehouse. That's Makueni, Murang'a, Kirinyaga, Baringo, Samburu, and Homa Bay. However, Machakos, Kiambu, Kajiado are also trying their best, apart from probably a few sites that are not able to upload. And those are the sites that we really need to focus on and find out what are the challenges they're having so that we're able to support them. West Pokot, Narok, Turkana, Nyandarua, Trans Nzoia, Mombasa are not doing so well in terms of uploading their data. I know these sites could be having challenges, and that's why I'm saying they need to reach out to us so that we're able to support them. Isiolo is one of the ASAL counties, and most of these facilities, most of the counties are still operating on IQ Care, and we are working on modalities on how to support them to be able to migrate to Kenya EMR and further support them to be able to ensure that they upload their data to the National Data Warehouse. So that is how the counties are performing. So we need to also look at how each of our service delivery partner, again, remember the denominator is still the 1,477 sites that have that have EMR or were able to upload their data, and USAID to Jenge Jamii, CHS, Tegemeza, EON, CRISP Plus, faith-based sites, county government of Siaya, all the way to AIDS Healthcare, those and Siaya CHMT. these are the sites, these are the partners that have been able to ensure that all the sites they are supporting are able to upload their data. What we are not sure, and probably we'll have a discussion later on, is probably what could be the challenges Hope Worldwide are facing, what could be the challenges HJF Nairobi are facing, and thus they are not able to upload their data to the National Data Warehouse. So probably we'll have a discussion to the tail end of this presentation so that we get to really understand where the problem is and come up with a way forward on how to support them. Similarly, USAID Imarisha Jamii and Migori CHMT, USAID Stawisha Pwani, LVZT prisons. I think we those are also some of the partners that we think they still can do better than what we are seeing in terms of ensuring that the sites that are supporting uploading their data to the National Data Warehouse. So then what exactly do we mean by a stale database? So these are databases that are uploaded to the National Data Warehouse, but do not have any clinic visit documented or any clinical information updated within that database. So what happens is at the end of every month, the expectation is that facilities that are using EMR should be able to upload the data to the National Data Warehouse. Within the database, we are able to tell whether there are any clinical information that was updated for the patients in that particular database. So what we've noticed is that when a database is uploaded, when you go into the database, you find out or you realize that the last time the clinical information for the patients within the database was done more than 30 days ago, or even 2 months ago, or even 3 months ago. So that's exactly what we mean by stale databases. So what happens here is that our colleagues tend to upload databases that do not have any clinical updates, because the expectation is at the end of every month, we expect that we have patients who are making clinic visits to the facility. We have patients who have clinic dates that are scheduled within the month. So we would expect some updates being made to each to the patients that were supposed to make a clinic visit to the facility. However, that doesn't happen, and that's why we end up having stale databases that are uploaded to the National Data Warehouse. So we would really encourage, it is incumbent for us to ensure that we update whenever necessary. When patients make visits to the facility, we update and ensure that we upload an up-to-date database to the National Data Warehouse. And if we don't do that, then it poses lots of challenges, because we are not able to determine the true status of our patients. And those are some of the potential effects. And when we look at the analysis that we've been able to do, one of the reasons could be the fact that we are uploading stale databases. So we are really not able to tell the true status of our patients, whether they're actually active or they're not active, because there are no updates that were made. So we are not able to tell whether they're actually dead, whether they're lost to follow up, no documentation at all. So we are not really able to determine our patient volume in terms of currently on care of patients. And that could also be the genesis of some of the concerns that we've been raising in terms of we've been receiving concerns that the number of patients currently on ART that is available within Kenya EMR and what is in the National Data Warehouse is different. That could also be one of the reasons as to why those numbers are different, because what is in the National Data Warehouse is not up to date. It's not same to what we have in Kenya EMR, which is a live system at the facility level. That's a system that we're using to manage our clients. So this is the point that we want to really encourage the county to work together and ensure that at the end of every month, we are able to upload up-to-date databases. So that is the analysis that we did, and that is what we'll be able to be taken through by Dr. Momanyi after I'm done with my presentation. And we only focused on outcomes from facilities. So what we did is that we tested out sites that are still databases, and we only focused on sites that were able to update, that had that had databases that were up to date. So we were able to tell that these sites at least had updated a patient record within the system. So that is what we were able to analyze, and the results that or the findings that we will project or will be able to share with you today is from those sites that were able to upload the still data. Up to date databases. The sites that uploaded still databases, we left them out because again that is a problem to us, and we really need to encourage our teams to be able to make sure that they upload at any one given time databases that are up to date. So one of the things that we would also wanted to just see is in terms of the absolute numbers, we wanted to just see in each of these counties how many facilities are uploading still databases. And that is what we discovered. Bomet County had the highest number with 7 facilities. Nandi had 7 facilities. Makueni had 5 facilities. Kakamega had 4 facilities. And then Bungoma to Nairobi, they had 2. And then the rest of the counties had
You lose Sangok?
Yes, sorry.
Oh, we couldn't hear you.
You can hear me now? Sorry.
Yes.
Can the rest of the team hear me?
Yes, we can hear you, Sangok.
Yes, you're back.
Oh, I got lost. Sorry. So at what point did you lose me? Sorry.
At the end of the previous slide, so it's okay to start from this one.
Oh, this one.
Yes, you'd already presented, so you can start with the partner.
Okay. Apologies for that. Yeah. So I was saying this are the number of facilities that are being supported by partners, or the facilities that are uploading still databases by partner. So you realize that HJF South Rift has 18 facilities. Remember that Walter Reed cuts across most of the counties in South Rift. That is Nandi, Kericho, and I think Bomet. So that is why they're having that number of facilities. And that is why I was saying we need to have a serious discussion on what could be the challenge in this facility so that we're able to support them. USID Boresha Jamii at 7 and CHEP Imara at 5. USID Jamii Tekelezi at 4 and Stawisha Pwani at 4. Then the rest at 2 and then 1. So that's the picture by service delivery partner. And the previous picture, the previous slide was showing us the number of facilities in each of the counties. So very quickly, in summary, it's good for us to really understand that facilities that are uploading still databases makes it very difficult for us who are relying on the data in the national data warehouse to be able to longitudinally track the HIV treatment cohort of patients. And you will appreciate that when we'll take you through the next session. We end up losing patients, and we are not really able to determine their status at any one given time because the databases that are in the national data warehouse are really not up to date. So we want to appeal to the partners and the county teams, that is the county health management teams, the service delivery partners, to support facilities to upload, to ensure that they upload their databases which are up to date and which have most recent clinical encounter information for clients made a visit to the facility. Yeah, so this is our rallying call. At the end of it all, we will, if we get time, we need to have serious discussions that we agree on the way forward. What place, what are the follow-up mechanisms that we need to put in place to ensure that we always endeavor to upload about what do we need to do to enhance timely reporting to warehouse. And then we've already seen the impact of uploading stale databases. We will not be able to tell the status of the status of our active patients within the national data warehouse, or we are not able to tell the status of probably if in case we lose anyone, we are really not sure whether they're dead, whether they're alive, whether they're active. So basically that's the main idea, and that is what we really need to agree on moving forward. So in case you have any questions, I should have started with this, just post it on the chat. We have a team to any of your questions. And at the end of our sessions, we also wish to get your feedback. I think Margaret had mentioned this. We would really wish to get feedback from you on how we can improve our webinars moving forward. So we have a short survey. We'll have a link that we'll share with you to just give us some quick feedback on how best we can improve our webinars moving forward. So I think that's it from me. Thank you very much. And back to you, Dr. Oramisi. Asante.
Thank you very much, Franklin Songok, as he has taken us through, and I think now you have a good understanding of what is happening, who is reporting stale databases, and what we need to do together as a country to just move it forward. So we have gaps, and the gaps have been clearly highlighted, and I'm really requesting that if we could take time to just reflect and be able to identify why is it that we're having these gaps and what do we need to do. It's open, give us feedback, give us suggestions, tell us what is the issue. For now, let's utilize the chat box for most of this. We will be able to, have that one-on-one on the chat box as we continue with the meeting. I will hand it over to the next presenter so that we can continue with the next session.
Okay, so let me stop sharing this, then Dr. Bomanya can share his.
Thank you, Dr. Lazarus. Over to you.
Thank you so much, Frank. Before I continue, I think I'll just allow Dr. Valeria Makori, if you can hear me. Dr. Valeria is the new technical officer in the care treatment unit, to say hi. Hi, Valeria. Okay.
Good morning, everyone. I've been told to say hi, but I'm joining the team. But you may proceed, Lazarus.
Thank you so much, Valeria. And I think back to the presentation, thank you, Songok, for setting the stage for the next presentation. And I think it's just building up on what you've been able to share, mainly around the reporting rates. But here now we're going to just take a little bit, just dive to look at an analysis that was conducted, and I'm just going to take you through this. And you're basically looking at the longitudinal tracking of the HIV treatment cohort using individual level data. As you've seen from Songok's presentation, one of the biggest advantages we have with the national data is that it's actually individual level data. So we are able to actually be able to conduct analysis that is patient level and be able to make conclusions based on the data that we are seeing. And so one of the analysis that was done was looking at the treatment cohort, and basically this is really looking at how are we retaining our patients on treatment as we are making progress towards epidemic control. I think one of the things that we really want to ensure is that we are able to optimize retention of our clients on treatment, and of course also the viral load suppression. So this is just one of the analysis that you're doing, and as we move on, as we have better data on the national data warehouse, you're going to conduct more analysis on other outcomes and present in future webinars. And I also just want to appreciate the team that was able to do this analysis, the team from our SI unit, and of course with our partners Palladium for this analysis. So the question really we looked at was what are the treatment outcomes as of 30th of November for patients who were current on treatment as 30th of September. So we used 30th of September as our baseline, and we looked at those patients at the end of 30th of November 2021. That's basically 2 months later. What were the outcomes of these clients? So just, just to give you a little bit of background on how this was done. One is that the analysis was conducted on data submitted to the National Data Warehouse for all patients, irrespective of when they started ART. I know we are used to the cohort analysis that we do, that we looked at a cohort of patients who started treatment at the same time. But for this analysis, really, we are looking at all patients, and we looked at patients who were on treatment that were determined as end of 30th of September. The outcomes of these patients were then assessed as of 30th of November, which is basically a 2-month follow-up period. So in total, the analysis was done or was tracked for 735,000 patients from 940 facilities out of the 958,214 who are the patients who are currently in treatment reported in the National Data House as of 30th of September. And I think this is what I was pointing out, that if you look at the total number of patients who are reported on as treatment current on the National Data Warehouse, you're talking about over 900,000 patients out of the 1.2 million. So this is almost 80% of clients. And therefore, if we actually, embrace what Songkok was saying in terms of having 100% reporting, accurate and complete reporting, then this is a very good sample, or really a proportion of our clients that we can use to make conclusive analysis for our various outcomes for treatment, and even any other kind of analysis that we want to do. So again, as it was pointed out from the first presentation, a total of 222,000 patients were not included in the analysis, because these were the patients from the 615 facilities that had still databases that I think Songkok has already taken time to show in the previous presentation. Again, we looked at these outcomes or analysis. We disaggregated it to service delivery partners, county, and age, as you'll see from the next slides. So again, before I go into the findings, we just wanted to ensure that we are on the same page in terms of the definitions that we are using. So current on ART is defined as the number of adults and children, that's basically patients on ART, who are currently receiving treatment, who have not missed their appointment, and that 30 days have not passed since the last missed appointment. So basically, or the last visit. So basically, this means I think we are all aware about the current definition of current on treatment, and it's basically the cutoff that is used is 30 days. And therefore, that is the definition that was also used for the analysis that was done. And for interruption in treatment, and so I think someone asking on the chat what it means. I know it's probably a new terminology to some of us or many of us. So it's a patient who started on treatment who did not honor their last drug pickup appointment, and at least 30 days have not elapsed since the last missed drug pickup. Yeah. So this, I think maybe if for those, maybe I know we are used to maybe the terminology defaulter, and maybe this is what is almost similar to that terminology that you've been using in the past that we're used to. So in terms of findings, so this is just the overall analysis, which I'm going to present some few slides to just show the, just allow me to hide something is floating. All right. So this is the analysis and the findings of the analysis that was done. So as you can see, as I mentioned, that the total number of patients who were analyzed was 735 patients. And from the analysis, those who are active, as what I've defined in terms of treatment or current on treatment, was 695,000, which translates to around 94.5%. But then from the analysis, we're also able to note that about 33,000 patients who were, which is translated to around 4.5%, were not on, rather had interrupted treatment within this 2-month period. And 0.8%, which is 5,600 patients had been transferred out. And those who had stopped ART was 1,376, and we had about 19 patients who were dead. So I think our focus really for this presentation is really to try to understand the patients who interrupted treatment and looking at when we disaggregated the data, which counties, which are implementing or service delivery partners, where are these patients are, and just to try to see the real picture, whether is it really the true or actual picture of what's happening with the patients, or is it also maybe related to what Songok was saying in terms of maybe not having accurate data reported in the national data warehouse. So when we looked at the distribution of the patients who dropped out of treatment, you could see that the patients who, the counties that really accounted for majority of these clients, and you can see Nairobi accounted for the majority of the clients, followed by some of the counties, including Migori and Kiambu and Mombasa. And you can basically see in terms of distribution, the counties that have actually really accounted for the majority of these clients is what you're seeing, like the first about 8 counties. That's Migori, Nairobi, Migori, Kiambu, Mombasa, Kisumu, Nyandarua, Kilifi, and Kisii, and Kakamega. That at least had over 1,000 clients who had interrupted treatment. And therefore, I think this just this slide is just to help us to be able to really understand what you're talking about and where these problems seems to be, more so that we can be able to go back, because this data is really available at the National Data Warehouse, and really be able to analyze and see where are we losing these patients. Is it issues about reporting, or if there are really true issues that these patients have interrupted treatment or did not come back for their visits, then what is being done in terms of really tracking these patients and returning them to care. So we again, as I said, also analyze this data by service delivery partner. And as you can see again, the distribution is there. You can see CF Entrench accounting for majority of the clients, followed by USAID, Jamii, Tekelezi, CF, and all the way to the other partners. So I think these slides are available for all of us. I think really this is really not to point fingers, but just to help us to understand where we can be able to place effort. The data, again, as I said, is available in the National Data Warehouse. We're able to drill it down to facility level and really see, for example, if you are a partner X, and these are the patients that we are saying that had interrupted treatment or dropped out of treatment by 30th of November, then which are the facilities within the facilities that you are supporting that are accounting for these clients, and be able to really, if it's really issues around data, to be able to correct that. But it's really truly that these are patients that who have interrupted treatment because that is what's reported or that's what was analyzed and the findings, then we are able to put in place mechanisms to ensure that we trace them and return them to care. So again, so this is just now, I know that the previous numbers I was presenting were absolute numbers, but this slide is just now looking at the counties, but specifically now looking at the proportion in terms of the proportion of clients who had dropped or interrupted treatment. So as you can see, the percentages are there. Of course, there's some of the counties that I mentioned that had the highest number of proportions, or rather the highest number of absolute numbers of patients who interrupted treatment. You can see that they don't necessarily have the highest proportion, but I mean, you can see strikingly some of the counties like Nyandarua that had a total of that 1% of their clients who are reported to have interrupted treatment. And this is really concerning because really, I mean, it does not make sense that you have that 1% of patients interrupting treatment within 2 months of a follow-up period. And therefore, we try to break it down, I mean, to just analyze data from Nyandarua and see which are some of the counties, sorry, some of the facilities within Nyandarua County that are accounting for this picture that you're seeing of that 1% interruption of treatment. And as you can see, some of the counties, it was really surprising that you have a facility like GM Kariuki that shows that 82% of the patients interrupted treatment. You can see Engineer 49%. And therefore, I think and as Soramis mentioned at the end of this webinar, really one of the things that we have to agree what needs to be done. And for such a country, we are just asking that the county team and also the implementing partners who are supporting the county, just go back and analyze this data and ensure that corrective measures have been put. We think that some of them could really be reporting errors or data that is not up to date. But remember that this is the data that's in the National Data Warehouse. So when we are looking at the data, for example, if we are planning to see how best to support Nyandara County, then this is the data that you are seeing. So what you report is what is actually reflects in the National Data Warehouse. So is this really data that the county can be able to use for decision making? I don't think that's the case. So even more important reason why we need to really ensure that we have just like with the way we report accurate data to the DHIS, we also need to report accurate data to the National Data Warehouse. So this is, again, in the other slide I'd shown you the proportions of patients who had, sorry, the absolute numbers in terms of by partner. But this again now is looking at proportions by service delivery partner. And again, as you can see, strikingly, some partners who have very large proportions of patients who have interrupted treatment within the 2-month period, like Kogri, which is, we see there is 62%, again, very, I mean, something that really is hard to understand how that can be the case. You can see some of the partners having as high as 16%, 15%, and so on. So again, this is data that we just put to help us to really to be able to visualize what you are talking about. This is the data that is reported in the National Data Warehouse from the facilities that the service delivery partners support. And this is really a call to action for us to go back and look at this data. I know some of us, the counties that we support have very, I mean, high volume facilities, and really trying even to analyze data from I'm using paper-based systems is really very difficult. So really we are saying that EMR is the way to go for reporting, for documentation, and even for analysis. Then we really need to look back and see the data that we have from the facilities that we are supporting. Is it really accurate, and is it showing us the right picture that we want to see? So this, I think one of my last 2 slides, this was just trying again to disaggregate by age. As you can see, really no striking differences in terms of age distribution for those patients who interrupted treatment. And I think this is again is there for you to really to see, but I think we really didn't see a striking significant differences in terms of the age distribution of the clients. So I think just to, as we end this, and I know there'll be a discussion and questions that we can be able to discuss, but really to summarize is that we had 4.5 patients who were reported to have interrupted treatment within the 2 months period, or dropped out of treatment within the 2 months period. And this is probably, as you've seen from the breakdown, when it's segregated, it could be some of the issues. If you're able to really go down or drill down to which are the counties that are accounting for or are contributing to this, if you're able to really go back and address these issues, if it's data reporting issues or if they're really accurate, then be able to find these patients and return them to care, or then I think really we'll be able to improve our treatment cohort, I think, as Dr. Masamaro said. And so as we discuss, I think really one of the things that really can be able to discuss is what is really contributing to the leakages that you're seeing in the treatment cohort. Thank you, and back to you, Dr. Ramisi.
Thank you very much, Dr. Lazarus, for taking us through that. And I know that I have my co-moderator now, who is Ndisha, who will be supporting us, just take us through the presentation that Dr. Lazarus has made, and in case we have any issues, and she'll take it up from here. Ndisha, welcome.
Thank you, Dr. Violet. And I have the great privilege of stepping into very big shoes of Dr. Masamaro. So I hope I will do his session a justice. So first, I would just like to, okay, I can see a hand. So I don't know if there's a question from the presentation, if we can start from there. Mike Ruto, is your hand up? He's put his hand down, and I see now Clement. Songok, do you just want to maybe guide us? I'm not sure I understand.
Hello.
Yes.
This Clement. Hello.
Go ahead, Clement.
Yeah, I've just been following the presentation, and I can see we have a good number in our West Pokot. I know we are struggling with loss to follow-up. That is a monster with us that we are struggling to get solutions. But last time, the case-specific surveillance, that is CBS, that is getting data from the national warehouse. And I don't know what is the relationship between these and what is found in the national in the CBS, sorry. And again, most of our facilities are not able to upload the data to the national warehouse. So I think we have a gap on how to upload the EMR data to the national warehouse. Thank you.
Thank you, Clement. I think I see somebody, is it Dennis, who wants to say something? Are we able to allow him? Songok, Dennis Osiema would like to.
No, Margaret. I didn't want to say anything. Thanks.
Oh, okay.
Yeah, so Dennis Oshemo is part of the panelists. So I needed to promote him to the panelists, but I've done that. Thanks, and sorry, Dr.
Okay, so Songok, I was just saying, could you kindly guide us? There's a question from Clement, and then I don't know, we might suppose do Q&A, or if you could just guide us, I would really appreciate.
Yes, so the Q&A will come immediately after Kezia's session. So I would kindly request that we hold on till Kezia is done with our session, because that's what we are doing next. And then we open it up for panelists plus Q&A session. So that should be the guidance. So just for the attendees, just hold on to your questions, take note of them. But in case you are in a position to post them on the Q&A wall, kindly do that. We'll be able to respond to them. But if you feel that you need to verbalize your question, then you can hold on to that till we are done with the next session. Then we'll give you an opportunity to ask your questions kindly. Thanks, and back to you, Nisha.
Excellent, thank you, Songok. And so I'm seeing hands, so those with questions, kindly you can type them so that you don't forget as well. That way we can have people attending to them. So Kezia, are you ready to upload your presentation?
Yes, I am.
We can hear you, so we're waiting to see your screen.
Is it up?
Yes, it's up and it's on presentation mode. Karibu sana.
All right, thank you. Good morning, everyone. Kezia Merori, I'll be taking you through the COVID-19 module in Kenya EMR, which was added last quarter and is already out there at the facilities. Looking at starting with the overall goal of this module, it's helping us monitor the uptake of vaccines among the people living with HIV. Again, it's helping in monitoring the occurrence of COVID-19 among the PLHIVs, as well as in monitoring effect of COVID-19 on appointments and mortality among the people living with HIV. So the focus really of this module is a COVID-19 vaccine uptake among PLHIV who are above 15 years, according to the ministry's guideline. So initially we started, we were at 18, but once the revision was made to include 15 years and above, the same adjustment has been made in the EMR. We are also focusing on getting the history of COVID-19 infections among active people living with HIV/AIDS, regardless of their age. So looking at everyone who is enrolled in HIV care, and if they have been tested and if they have ever tested positive for COVID-19. On Ushauri, we have enhanced the messaging to include COVID-19 messages, just reminding the clients to go and take their vaccinations against the COVID-19. So allow me to just briefly go through the screenshots so that we have an idea of what you'll be seeing in the EMR. I'll be doing a short demo on in the EMR. We have been able to do to have a built-in form for which we have labeled as COVID-19 assessment form in Kenya EMR, which we can access through various apps on the homepage, the Traj, the Clinician, the COVID-19. Then we have a client who is very new or a client who is already enrolled in HIV care, but they have never been assessed for COVID-19 vaccinations. You can see we have alerts on eligible and all that. So we'll be able to see this live on the system. So I'll just go through this briefly. So for a client who has maybe a sample of the form is shown and the variables that are there, we'll be able to fill this together. Then we have a client who has maybe been partially vaccinated and they're coming back for a subsequent visit. Then you'll be able to see part of the history and then a provision for you to update the data for the current visit. A client who has been fully vaccinated, we have an alert just flagging the clinician, letting them know that this client has already received their full vaccination, and maybe now what they can just document is the booster dose. Then just to help in tracing and documenting clients who maybe missed appointments due to COVID reasons, we enhanced the EMR to include reasons for missing appointment. And we have about 2 reasons specifically for COVID-19, which you'll be able to see in the EMR. Then for clients who passed on or died due to COVID-19 complications, again, we enhanced the discontinuation form to include the COVID-19 complication. And again, we'll see how we document that in the EMR. We have a report with a number of variables and indicators that we are focusing on. We'll be able to go through the indicators one by one when we're in the EMR. And also we have a dashboard for the same. So that's just a snapshot of what we have in the EMR. So if you allow me, I would want to just share a different screen so that we do a short live demo of the module. So confirm that you can see Kenya EMR homepage.
Yes, we can see.
All right, thank you. So I'll be using a client who is already enrolled in the facility and who is already on a current visit, just to save on time. So we have our client who is called Eunice, Europe. So once you have a client, you have already checked in for an active visit, then the next thing would be to access the COVID assessment form. And we said we can access it differently, either via Traj, you'll be able to see the COVID-19 assessment form. Also, a clinician, under the clinician app, you'll be able to see the same, the COVID-19 assessment form is still accessible from there. And also we have an app specifically for COVID-19. And on this, you're able to see first the history, if the client has received any vaccination and all that. And then you can access the COVID-19 assessment form. So this is just helping people to access this from different points, because at times it will be filled at the Traj, it can be filled by the clinician, or anyone who wants to access this. They have those 3 sections where they can access it from. So to update this, just click on the form. Then we have the encounter date. I had already done a check-in, backdated one, so that we just see what happens on subsequent visit. And then we have the first variable that we're looking at, which is if the client has ever been vaccinated. So maybe before even I continue, for clients who are below 15 years who are not eligible for vaccination, then this question won't be there, and they will only have the diagnosis and management section. So that's the difference between the under 15 and the over 15. So if you say that the client has ever been vaccinated, that is when you access the section for vaccines. So we have all these listed, and if there is any other, you just pick. So allow me to use AstraZeneca. And assuming our client was vaccinated last, let's say 15th September, if it has been verified, looking at maybe they got an MOH SMS that they usually received. So you verify if that was given. So if not, then you just leave it blank, or you just tick for those that you verified. So this client, since we assume that they have just received one dose, we'll say their vaccination status is just partially vaccinated. Then we proceed with the booster dose for those who have received. It's either yes or no. So for now, I'll just say no. But if you say yes, then you can update this. Then moving to diagnosis and management for the client, whether they have ever been tested for COVID-19. If it is a no, then the form will end at that point. But for those who have been tested, then we proceed and check the test results for this client. If negative, again, it ends there. But for a positive client who tested positive for COVID, then we proceed and provide the date. So maybe we can assume maybe they were positive, maybe 15th of November, and we want to know the presentation of COVID-19, whether it was symptomatic or asymptomatic. So if asymptomatic, again, that will end at that point. If symptomatic, we need to know if they were hospitalized or not. So assuming it's no, then the details on the hospitalization will collapse. And then if it is yes, then you proceed and provide more details. So on admission unit, we are giving either the client was on isolation, HDU, or ICU. So you record the highest level that they were hospitalized in. And then we are looking at whether the client received a supplemental oxygen. And if it's either it's a yes or a no, and this form will end at that point. So maybe something I didn't highlight when I started this form is the note on the clients who have not been assessed for vaccination. You'll get these alerts just to trigger or alert the clinician that we need to assess for vaccination of this specific client. So once you fill this, then the next thing is just to save the form by clicking on enter the form. So I can end this visit at this point, and we just see what happens to this client. So if this visit was on 2nd December, so I just want to end it at that point. Sorry, there are issues with the dates. Just allow me to use today's date to clear that. Yeah, so the client came for the first visit, and we filled in first dose for this client. So you see the alert has now been updated from eligible and to partially. So when you come back to the COVID-19 dashboard, you see we have the vaccination history showing you when the client was last vaccinated or when they took their first dose and the vaccine they took and whether the verification was done. So the next thing would be when they are coming back for their next visit, have they received another vaccine or not? So I'll check in again this client, and assuming now on this day they have again received another dose. So if the client has been vaccinated since their last visit, if yes, then we update the other dose. So assuming now they received this in November 15th, and this was verified, then you see the status now has been updated to fully vaccinated. Then now I can skip this just for learning purposes, but every visit, the healthcare provider is able to update on diagnosis and management of that client. So we can save this Sorry, I didn't update this, and then we enter the form. So this will be repetitive for each and every visit. So you see again, the alert has been updated to fully vaccinated for COVID-19. So that's all about the form. But like we saw from the presentation, we had other sections which are more on tracing and having updated the reasons for missing appointment. So you go to patient tracing, and under HIV defaulter tracing information, we have the tracing form. So you'll fill in the date when this client has been traced, whether it was a call or physical or treatment. So assuming this client outcome was contacted, that's when you'll be able to access this section for reasons for missing appointment. And under the reasons, we have these two reasons that were added, whether the client has COVID-19 infection and COVID-19 restrictions. So if any of that, then we'll be able to monitor and know how many of our clients are missing appointment or maybe missed an appointment because of COVID-19 reasons. So this form was enhanced to just allow us to that. So allow me to just discard this since it's just for demo. The other section was on discontinuation form to record deaths due to COVID-19. So on the discontinuation form, let's use today's date as effective, and then the reason, if died, then we have the date of death, the death reason. So from the death reason, we need to capture under HIV disease resulting in other infectious and parasitic diseases. So when you select that under specific cause of death, we have COVID-19 complications. And that's where we should document that to help us track deaths due to COVID-19. And that's it for the discontinuation part. Again, allow me now to save that. On the reports, on the reporting side, we have a report on COVID-19, which is under HIV tab on the reports, COVID-19 report. The procedure for generating this is the same with all the other reports in Kenya EMR. So maybe I can just use 1st November to now, but we already have one that is, we can pick the most recent. So these are the indicators that we're looking for. So we said our eligible population for vaccination is 15 plus. So for this, we are using a test server. So you'll see we have very few numbers. So our eligible population in this database is just 6 clients. And out of those, we have 0 who are partially vaccinated, 2 who are fully vaccinated. And then from that, we have 4 who are not yet vaccinated. So we are able to tell or know how many of our clients are not vaccinated. And by not vaccinated, we are looking at anyone who maybe they have already come to the facility and have confirmed that they have not been vaccinated. And also those who have not yet honored their appointment since the module started being in use in that facility. But to allow the facility just track those who have not been assessed for COVID-19 vaccination, then we have this unknown vaccination status. We are calling it unknown because they haven't made a visit and we do not know whether they are vaccinated or not. So we will only confirm their status once they get to the facility. So the users can use this link just by clicking on the number, get the line list of those who have unknown status, and maybe they can even call them and just request them to come to the facility so that they have their details updated if that is needed. We are able also to see those who have verified first dose, those who have verified second dose, booster dose, and that, all the doses. Then we have those who have ever been infected with COVID-19, can get the line list of the same. Those who have ever been admitted to hospital due to COVID-19, and those who died of COVID-19. So these are the line lists that have been availed for COVID-19 report, and just to help the program track all this and get the data around the same. So apart from the report, we saw a dashboard, COVID-19 dashboard. On the facility dashboard, we have a section that was added on COVID-19. So you see, initially we had up to differentiated care, but now we have an addition of COVID-19 section. And we have one section looking at the COVID-19 vaccination, where we are looking at those who are partially vaccinated, fully vaccinated, and those who have not been vaccinated. On the right, we have the COVID-19 infection chart, where we are also looking at those who have ever been infected, those who have been hospitalized, and those who may have died of COVID-19. So from this, that's all we have on COVID-19 in the EMR. This data is also being uploaded to data warehouse, but I'm sure in our next webinars, we'll be seeing data or analysis based on the COVID-19 data, and you'll be able to have a look at the same. So my urge again is to the partners, the end users of the facility, let's ensure that we update all the data on COVID-19 in the EMR so that we are able to get a complete data set in the National Data Warehouse. Thank you, and back to you, Isha.
Thank you, Kezia, for that very clear presentation. And yes, if you guys have time, you can go to the warehouse. You'll see the, per IP, you can check the PLHIVs that have been vaccinated, and also per county that's already on the dashboards under the HIV treatment tab in the warehouse. So thank you for that. And I think I'm supposed to hand it over to Dr. Osiemo for Q&A. I hope you can hear me.
Margaret, thank you. I can hear you.
Okay, karibu sana.
Thank you, the presenters, Franklin, Lazarus, and Kezia, for the concise presentations, very clear. Quite a number of questions have been asked and answered. And, we have identified quite a number of gaps, and just emphasis on the importance of proper data entry, because Kenya EMR is a very important resource which you can continue using. And hopefully soon we'll go paperless, but first we have to ensure that proper data is entered. We are entering the data. Quite a number of questions have been asked and answered. I will request, I know Diana and Mary have answered a number of questions. I noted some of them came directly to the hosts. I don't know if there's anything you can add to the answers that were, to the questions that were asked. Mary and Diana, anything to add?
Hi, Dr. I have nothing to add unless the people who ask the questions would have additional questions, then we can respond to those.
Okay, thank you, Diana. Dr. Vakil asked, I think this is to Kezia, whether the COVID screening form is mandatory. Is it?
Maybe to respond to that, it's not like a mandatory form, but it is available at all visits for the clinician to update. So it will always be part of the available forms for the clinician.
Thank you, Kezia. And then there was a question of possibility to include MOH recommendations on the booster shots. It has to be done after 6 months.
That's something we need to enhance. We will pick that up as a recommendation. I think it's a good thing to have so that we don't have a data that is not representing what has been prescribed by the ministry. So I think for booster, we will restrict that to only be updated after 6 months as per the guideline. Thank you.
Thank you, Kezia. Darius has a question on pushing data into the national data warehouse on the possibility of having a central DWAPI for pushing data from multiple databases at once because of poor connectivity in some sites, which now present a tedious process. Anyone can answer that?
I can pick that up. So we have received this request as part of our enhancements to DWAPI. So we are still reviewing and just trying to understand how this can be actualized to make work easier for the facilities and also the partners that are uploading the data centrally. So as we speak, we don't have a solution yet, but we are still discussing on how best to support that scenario. Over.
Thank you, Diana. Then Sudi asked for clarifications on the ages for assessing diagnosis and vaccination status. I believe it's 15 and above. I think that's what we have in Kenya. Is that right, Kezia?
Sorry, come up again, please.
The ages of vaccinations, assessing diagnosis and vaccination status.
Yeah, we have vaccination for 15 plus in Kenya EMR.
Okay, so it's in line with the national guidelines.
Yes, it has been updated.
Okay. And there was also another question whether Kenya EMR captures which test was conducted for COVID-19, whether it was PCR or rapid test.
No, currently that is not there. We are just looking if the test has been done or not, but not the type of test used.
Okay. Any other question?
Dennis, there was a comment. There was a comment from Clement from West Pokot. I think it wasn't really a question, but it was a comment, and I like the way he put it because in West Pokot they've already realized where issues are in terms of, because you mentioned that they have a problem with they're experiencing most of their clans getting lost to follow up, which is an issue that they've already realized. So I think it's incumbent of the county teams, and this is the emphasis that we really need to put forward to ensure that once they realize that this is the problem, what are the measures that they need to put in place? Because this doesn't only it's not only in West Pokot, but it really cuts across some of our counties. So what do we really need to do as county health management teams, as a CASCOs and the service delivery partners to ensure that we put in place mechanisms to be able to trace these patients who are getting lost to follow up. So Clement, kudos, you've notice the issues that you're facing. So I think what you need to do is have a sit down with your service delivery partners and the other health management teams, the sub-county teams, the facility teams, and come up with ways and means of trying to follow up on those patients that are getting lost to follow up. Yeah, thanks.
Thank you, Franklin, for that, and Clement for highlighting the challenges that you're facing. Really appreciate. Kezia, there have been comments on the lack of the module in some of the Kenya EMR versions. I don't know if you can comment on that.
So maybe on the versioning could be the facilities are not yet upgraded. So what they need is just to liaise with their implementing partner to have their servers upgraded to the current version.
What is the latest version?
We have 18.1.2, but like I mentioned, this went out in November. So even 18.11 had COVID-19 module.
Okay. And then Beverly says she has issues when it comes to backdating. I don't know, is it possible to backdate the COVID vaccination status?
Yes, yes, you can do that, but I'm looking at a client who is coming in today. You don't need to backdate to the date when they were maybe vaccinated. So you just need to open the form, access the COVID-19 assessment form. And then when we come to the vaccination status, that is when you're filling the vaccine and the date when that was given. So we don't need like to backdate to update the vaccination status. We are updating the form as of today when the client has presented at the facility.
Thank you, Kezia. I also note that some participants are noting that the COVID-19 icon is not in their latest version. I don't know what you can comment on that. And they're using the 18.1.2.
All right, maybe on such scenarios, maybe it's a unique case. They can always reach out to our service desk and have that fixed, because it should be available for everyone.
Thank you,
They'll post the service desk number. Yeah.
Yeah, and the service desk number was I think Diana shared on the chat.
All right, thanks.
Yeah. I think we have covered all the questions unless there are any other questions or comments from the panelists.
Enoch's hand is up, Dennis, so let me allow him to probably ask his question.
Okay.
So, yeah, so.
Hello.
Enoch, yeah, go ahead.
Yeah, maybe just to add on what was discussed previously about the COVID-19 not being seen on other modules. I think these are all based module that you need to assign a user so that they are able to see the COVID module on the dashboard. Yeah, that's why some of the users are missing that module. If you access or you've given some rights to view it, is when you are able to use the module.
Thank you for that clarification. Also, Joshua has a comment on the challenges loading, making DWAPI loading from EMR experience an error. Facilities that have patient visit extracts with a value more than 200,000. I think Diana can answer that.
Come up again, Dr. I didn't get the question.
So let me read it, see whether they can understand. There are facilities that have patient IPT and patient visits extracts with a value more than 200,000. This makes DWAPI loading from EMR experience an error, and therefore it's not loading. How can this be sorted?
Okay, we are not aware of such a challenge. Personally, I'm not aware of such a challenge, apart from internet connectivity for that particular facility. But if you're experiencing such a challenge, I would encourage you, if you can just call us directly. Maybe this affects a unique facility so that we can assist. So I'll still post the number on the chat so that you can just reach out to us directly for that specific facility. Over.
Thank you, Diana, for that. Franklin, I don't know whether there are any other hands or any comments from the panelists.
Yeah, Rebecca Awinza's hand is up. So probably she could go ahead and ask a question or make a comment.
Rebecca, we can't hear you.
I was asking about the courses can they be linked to the MCD10?
You're very faint. I don't know whether anyone has heard Rebecca's question.
No, we can't. We don't seem to hear her.
Can you come closer to the mic?
The chat box has my question about the causes of death.
She says she's written her question on the chat box.
Yes. I'd encourage you to use the Q&A instead, because it will be easier for us to look at the questions.
I found it. She's asking if the causes of death can stick to ICD-10.
Any response on that?
Kezia, would you want to respond? I think Rebecca's concern is that I believe at the moment probably COVID-19 may not be available in the ICD-10. ICD-10 is the International Classification of Diseases, which is basically used in most of our facilities to code cause of death. So probably that is what Rebecca is. I mean, her concern could be on that line. So I would say that it's something that probably we could revisit and see how best we can be able to align with what is available and see whether we can be able to change that, but we'll have discussions on the same. I hear what our concern is. Thanks.
Thank you, Rebecca and Franklin. Sasi had a question on. She's asking whether the HIV status stroke ART use linked with the COVID reports at an individual level. Are they linked? Have you gotten the question?
I think I can take that. So yes. One, for the HIV status bit is that all the clients that we are targeting right now are those who are already positive and currently on treatment. So by and large, it means we are managing the positives. Now, because it's individual level data collection, they are definitely linked. The only problem is that we don't have the negatives being captured within this particular process, because remember, we are tracking our treatment cohort from this particular, from the EMRs. Over.
Thank you, Dr. Kimanga. I also saw that you had your hand up. Did you have any other comment?
Yes, I think I really like a comment that came from, first, I really want to appreciate the great presentation and the great discussion. I like what Evelyn has raised, and I think the question is that, where is the comment? It's disappeared from here. Whether we can do, come on, it's disappeared. Whether we can do root cause analysis for IIT, and I believe the purpose of this presentation was just to show us from the cohort that has been on treatment, what proportion is gradually falling off, and that number is relatively high. Our goal is to work with the implementing partners and the counties to ensure that every month when a client drops off, they are flagged. And once they are flagged, then the expectation is that we can follow up and bring them back to care. Because remember, our overall goal is to continue growing the treatment cohort so that our patients can benefit from the services that we provide, and by extension, achieve and sustain viral suppression. So the point that she has raised is a very important point, and we really are happy to work with you to ensure that the system can help in flagging, but at the end of it all, the action at the facility needs to be driven. Once there's flagging, then we expect action at the facility level to bring these people back, and then where possible, and over time, we hope to even get to the extent of being able to predict who is likely to be lost to follow up, so that once these ones are flagged, then we can take an action to try and prevent loss to follow up or interruption in treatment. Over.
Thank you, Evelyn, and thank you, Dr. Kimanga, for those comments. Dr. Vakil emphasizes, I think, the importance of ensuring that we have quality data uploaded into the EMR. She notes that there's some we still have some data issues in terms of actual ART regimen documentation. for example, less than 2-year-old child on TLD, weight documentation for children and adolescents living with HIV, a very low adverse event reporting, and actions taken for those who develop adverse events. Thank you, Dr. Vakil. I think for us to actually use the EMR, we have to ensure that the data quality is good. I think we don't have any other questions. I will hand it over back to Margaret. Or Franklin.
Maybe, Dr. before you hand over, I see there's another question that has been posted and some participants have raised some hand.
Oh, okay, okay.
Yeah. On the Q&A.
All right. Franklin, you can unmute those who have raised their hands.
Apparently, actually, I'm not seeing any hand up for now, because I think the people who had raised their hands have given them an opportunity to verbalize the questions, and they've been able to ask. I'm not seeing any hand from my end. Dr. Modoka?
I think that was the legacy hand, but
yes, probably.
There's an additional question from Darius requesting to maybe adjust the connection timeout span from the WAPI end, and I think we can look into that. I think that was the additional question as Tim was completing.
Okay. Yeah, thanks.
Thank you. Thank you for that. There's also a comment from Evelyn about interrogating transfers out. I think we continue to encounter quite a number of transfers. As a country, if you look at the data that we have, we have a net loss of transfers out. And one of the questions is, where are they going? If you look at the data from a country perspective. So I think better interrogation of this data will give us more insight. I think I'll hand it back to Franklin or Margaret. Thank you.
Yes, thanks. Thanks, Dr. Osiemo, for taking up that part. Margaret, you still there?
Yes, I'm here, Songo.
Okay, fine. I think we are coming towards the end of our meeting, and most of our managers have dropped out for another meeting. They're having a managers meeting, but I'm glad Dr. Winnie is still here with us. So I think Dr. Winnie will take up the next session, just in case there are no other questions. I can see we're about 13 minutes to 10. So yeah, Dr. Ramis is still here. Okay, fine. Yeah, but Dr. Winnie, you can take up the next session as we come towards the end of our webinar. Dr. Winnie.
Thanks, Frank. And thank you for the really nice session we've had. I'm seeing the attendance has been good since we began. We started with low numbers, but now we are almost at a 400 mark, and I really want to appreciate everyone who attended. So looking at the program, we are coming towards the end of this session. Franklin, just to confirm with you, you were to also administer a survey. I don't know at what point.
Yes, that's exactly what I want to do. I want to project the link so that they can be able to quickly give us some feedback. So as you do your session, I'm projecting the link so that they can be able to quickly give us some feedback. Thanks.
Okay, thank you. So this has been the webinar where we've looked at longitudinal tracking of the HIV treatment cohort, and also the double pandemic, being able to report on it. As we come to the end, we've also really appreciated the session on the Q&A, where there has been more learning in terms of just ensuring our data is complete in terms of entry, and also that our facilities are able to use the data that they are also entering. So as we come towards the end, I would like to have closing remarks. We know our partners and NASCOP also gave opening remarks just to put context to this meeting. So as we come to a close, I'd like to call upon beginning with Palladium, our representative from Palladium, I don't know if it's Dr. Jacob, to give the closing remarks. Just a minute to give your closing remarks. Thank you, and over to you.
Yes, can you hear me?
Yes, you can hear you.
Okay, yeah, so thank you for the opportunity to just say a few remarks. I think from our end, we appreciate the opportunity to provide solutions and data to the program and the clinical care teams that support the delivery of services. Within the EMRs, we continuously engage with partners and users to just ensure that you have tools that can help you to account for clients. And I think as I've seen from the chat, Evelyn has raised two important comments: the issue of just drilling down to the IITs, doing a root cause analysis, and also just exploring the transfer outs. We have provided tools to help partners to engage across facilities, both through the mHealth solution and through Kenya EMR, so that you can be able to verify the transfer status of clients. And I think we can now look at that from the data perspective to see how we can again improve on this. I think an important thing that would be good to consider after this is now to go to do this kind of undertaking at a sub-national level, so that we dig deeper with partners collaboratively on some of these outputs and insights we have received today, so that we do not end this process here. You know, we move it to program improvement era and make sure that we are able to support. I think having said that, thank you so much for the chance to engage with you using this data, and we look forward to the next one when we can engage further. Back to you.
Thank you. Thank you, Dr. Odhiambo, for your sentiments. We at NASCOP also appreciate your support, especially as you talk about constantly improving the data systems to remain relevant to the changes and what you're seeing around. So thank you very much to the Palladium team led by yourself. Next, we'll go to the DoD representation in this meeting. Sorry. Yeah, so I'm not sure who's representing DoD in this meeting, but I'd like to give them a minute to just give their words, their closing remarks. Also, just to remind you that the link has been sent in the chat. You can continue giving your feedback. Thank you.
Hi, good morning. Thank you very much, Dr. Winnie. This is Dr. Maswai Jonah, the Care and Treatment Lead for DoD. And I just want to register my appreciation for this session. It has been really very enlightening. And also speaking as part of the clinical ITT, I think these are some of the sessions that start giving us answers for some of the questions that we've been having. Because one of the issues that we've been grappling with over time has been the issue of treatment interruption, the issue of very slow net cohort growth, in spite of all the efforts we are making to bring in new patients and trace back the ones who have been lost to follow up. It has not really been showing in the cohort growth. So I think such analysis at patient level are beginning to show us some of the answers to some of these puzzles that we've been having. And I really want to appreciate NASCOP and all the partners for really doing this. And I look forward to such sessions continuing to enable us to be able to consume our data and make that data to inform our planning, especially at this time when we are beginning the COP planning process. Such data is extremely useful. So thank you. And as an agency, of course, we fully support the implementation of EMRs, and will continue encouraging our partners to fully upload and, more importantly, make use of this data to inform their programming. So from me, thank you very much, and hope to continue benefiting from this great initiative. Over.
Thank you, Dr. Jonah. The collaboration is always appreciated, and we also just appreciate this forum for us to be able to interact with the facilities and our representation in the counties. This is very valued, and we hope to continue having this. So as we progress, I'd just like to go back to the Palladium team and recognize the presence of the project director, Pascal, and I'd just like to give him a minute to give his remarks as well. Thank you.
Thank you very much, Dr. Winnie. Please confirm if you can hear me.
Yes, I can hear you.
Okay, great. So I just want to thank all the participants for making time for this meeting today, and the team from NASCOP for leading this process. As always, we appreciate the NASCOP leadership in this, and of course the partners. So I just wanted to follow up on a comment that was raised on the importance of doing root cause analysis to look into the cause of IIT. The reason we have these meetings and forums is basically to shine a spotlight on the data, find any quality gaps or program performance issues, and come up with a plan for resolution. So I'd really like to encourage all of us to work together to resolve any program performance issues that the data is showing us. We at Palladium Kenya remain committed to ensure that the technology evolves with the programmatic needs and that it responds to the evolving requirements from the end user perspective and also from the programming perspective. So asante sana for the time, and we commit to continue supporting you. Thank you.
Thank you, Pascal. As we progress, I'd also like to call upon a representative from the USAID team, Dr. Siemo and team. One of us can give their closing remarks. Thank you.
Thank you, Dr. Nyanya. I'd like to, first of all, thank NASCOP for organizing this webinar and the leadership that you continue to provide for us, and also the Palladium team for the support of this and all the participants in this webinar. You are the implementers, and we really appreciate the work you do. For me, I think what has come out clearly is that we need to ensure that we upload the data and ensure we have quality data, and so that we're able to use the EMR for decision making as we move ahead. Moving ahead, I think we'll work with the partners. We've identified the gaps that were brought out in the presentations, and work with the partners and support to immediately review and see where the challenges are, and support them to ensure that they continue maximally using the EMR, and hopefully soon we'll be able to have 100%. We go paperless, as Dr. Oramisi keeps telling us that we need to do. Thanks again, and wish you a wonderful day.
Thank you, Dr. Siemo. We really appreciate your leadership and your support, especially also as we recognize the implementing partners in the counties and the work they're doing to ensure that we have the EMRs up and running. So we really appreciate the USAID team. As we still talk about the USAID and the whole PERFA team, I would like to call upon Dr. Kimanga and the CDC team to give their closing remarks. Karibu Daktari.
Thanks, Dr. Winnie. For me, really, first and foremost is to appreciate the great leadership that NASCOP has provided. Dr. Violet, together with the program team, in moving the digital health solution agenda. I'm so happy that today we are meeting here to start addressing programmatic problems at using individual level data, which I think is very, very powerful. So thank you very much. I also want to thank Palladium Kenya for this great job. I mean, they've been supporting the digital health solutions for a number of years, and beginning this year, they've also taken up the mHealth solutions. And this far, I think you all agree with me that they've done a very good supportive job, and really want to appreciate them for that. Also appreciating the agencies that are represented in this meeting for the great work that they have done in terms of supporting the rollout and use of digital health solution, and also resource allocation at the national level to ensure that this work can get where it is and also go further to take us to the next level. And I know one of the things that we are hoping to do pretty soon is embracing machine learning to do lots of exciting predictive analysis. And we look forward to sessions where this will be discussed. Not to forget the implementing partners and the county teams for the great work that they have done to get us here. And again, I want to continue encouraging you. Right now, we are about 75% of our current on treatment being captured within the EMR. We want to believe that with your support, we can actually go to 85 or even 90%, so that ultimately, even as we report aggregate numbers, we can account and say these are the actual individuals that we have, and giving us the ability to drill down, especially as we near the last mile of epidemic control, where moving from 90 to 92 is more difficult. So the role of individual level data at this stage cannot be underscored. So again, we look forward to that further collaboration to really take us there. A lot has been said about IIT, loss to follow up and the stale databases. So I wanted to really move to the next level, which is the last part of the presentation, which was COVID vaccination. We know we've done a lot to really scale up our HIV program, to grow our treatment cohort to where it is. But then at the end of it all, we are getting to a level where we are preventing our clients from dying from HIV thanks to ARVs. But now they can die from other causes. And one of the major threats right now is actually the COVID pandemic. The only solution that we know of is vaccination. And I'm glad that through the EMR now, we have the ability to track vaccination of people living with HIV. And I really want to urge all of us to try and do our level best to ensure that the people under our care are vaccinated, fully vaccinated, and thereby protected against the adverse outcomes of COVID infection. I believe we have the tools, and I want to believe that we can take up the challenge, and pretty soon we should demonstrate that people living with HIV have not been left behind in getting vaccinated and thereby being protected from severe COVID or hospitalization and death. Once again, asanteni sana. I look forward to further collaboration, and I want to believe that we'll continue having these webinars and really see how best we can make use of these digital solutions to drill down to any of the outcomes within our program and really take proactive measures to prevent any adverse outcomes. Asanteni sana and bye.
Thank you. Thank you, Dr. Kimanga. You summed it up really well in terms of just appreciating the efforts of all the key players, all the way to our people living with HIV and the partners that are ensuring that this work is done, and the facility staff. So thank you very much. We are looking forward to continuing this collaboration so that you can have more solutions, and as you mentioned, innovations in tackling whatever challenges that you're facing as we progress in trying to solve any emerging issues in care and treatment of our people living with HIV. So I'd like to really thank all our panelists and all our speakers for this morning and this webinar. I'd like to hand over to Dr. Ramisi, if she's still on the call, so that she can lead with the final closing of this webinar. Thank you very much. Is Dr. Ramisi in?
She had indicated that she was to attend the managers meeting. So in her absence, then Faith can take over And as Faith prepares to take over, I'm hoping that every one of us was able to register before joining in using the link that was provided in the Zoom, in the Zoom link that was provided, because that is what we will use to reimburse some bundles for the MOH staff. So we will be able to download from our end. So kindly ensure that if you didn't register, probably if you're using someone's link, please make sure you register, because that is what we will use, especially for the MOH staff. That's what we will use to reimburse airtime for the MOH team, especially the CASCOs, the subcontinents, CHRIOs, and the rest of the MOH team. Thanks. Faith, you can take it up, because I think Oramisi has oh yeah, she's back. Thanks.
She's on the call, so I think she can proceed and do the closing remarks.
Sure, thanks.
All right, thank you very much, everybody. And I would like to really appreciate, first of all, the NASCOP team, Charity Begins at Home, our HIS lead, that is Faith Ngare, and also the IPs that are supporting us at NASCOP. I really want to appreciate you for putting this together. I also want to take this opportunity to appreciate the Palladium team that has worked together with the NASCOP team to just make sure that this gets done. And we can all attest to the fact that the work that has been presented today, you can see that a lot of back-end preparations had to take place and a fantastic job has been done. I really want to appreciate you for that. I also want to take this opportunity to appreciate our colleagues from PEPFAR and to appreciate our colleagues from the counties for ensuring that we are where we are today, and we have been able to highlight the gaps that we have noted, especially when it comes to issues around reporting, and just ensuring that as a country, we are actually able to grow our HIV treatment cohort, which really remains a priority for all of us, and especially as you see that we have really put in a lot of investment to ensure that we have reached where we are today, but we need to actually make sure that we can see a net growth of our cohort based on all the years and all the efforts that have been put by all of us at different levels of service delivery, or also at different services, at different points of implementation. Head NASCOP was to join us, but unfortunately, I think she's still held up in a meeting. We have many meetings that are taking place today, so apologies for that, because I know some of our managers have already had to drop off. We have another physical meeting, but we all have blessings, and she's really committed to the fact that as a country, then we need to see how do we put in all our efforts together to ensure that we're able to end this HIV epidemic. Colleagues, today you have seen that it doesn't take one person to achieve the milestones that we have been able to achieve. And I really want to appreciate the service delivery partners on the ground, our colleagues who are supporting HIS, not only Palladium, but all our colleagues who are actually ensuring that this actually gets done. The USG team, the NASCOP team, and all the experts. And even as we are working together, you've seen that we really have like about 33,200 PLHIVs who we've been able to bring back, and we really want to make sure that we keep them on treatment. I want to appreciate especially the leadership from the care and treatment manager at NASCOP, and also our colleagues from the other IITs, just to ensure that we are able to work together to ensure that we keep our PLHIVs alive and we keep them on treatment. As we have started this webinar series, as my colleague Dr. Kimaga has already highlighted, we are planning to have many, many more so that we can appreciate the work that we are doing. And data for sure doesn't lie, the numbers don't lie. And you can see that if you have an area where you need to improve, then we need to pull up our socks. And we will continuously do this so that we can get to the next level. Remember that even when it comes to reporting, like for example, the National Data Warehouse, we have really improved, though we noted a slight decline, especially around December, where our reporting rates dropped to about 80% from 84% where we were previously. We want to put in a lot of efforts to ensure that all of us are actually able to report, and not only report, as Dr. Vakil highlighted, we want to have quality data that we can be able to utilize with confidence at different levels of service delivery, or even at different levels of policy making where we work. So I want to wish all of us a very good start and to encourage us to do our best. And if you have any challenge, you have been given the numbers on the chat, please call those numbers. And especially now that you also know that we have the COVID-19 module that is there. We do not want to have clients dying because they were not vaccinated. When they come to the hospital and you have the opportunity to ask them, have you been vaccinated? And you're able to update their vaccination status to ensure that they are fully vaccinated. Even that interaction and having the module also serves as a reminder to us as clinicians that we need to ask these questions. So our clients remain priority to us, and I'll urge all of us to do whatever we have to do to make sure that our clients stay alive, they're on treatment, and we retain them in care. We will continuously monitor their data, and we will continuously share data at different forums to just make sure that we do what we're supposed to do. I want to thank you all for taking time to join this webinar this morning, and I would like to really wish you a Happy New Year and to also wish you a lovely day. And we look forward to having more engagements and more collaborations so that we make sure that we're able to monitor this HIV epidemic. Thank you very much, and back to you, Songok.
Thank you very much, Dr. Ramisi, for those closing remarks. Like I mentioned earlier on, the Zoom link that was shared with all of us had a part for registration. So kindly register, even if you've not registered right now, go back to the Zoom link and register, because that is what we will use to be able to reimburse your airtime. We were not able to post the link during our webinar, but the link came with the link to registration came with the link for the meeting, so to say. And then please don't forget to also give us quick feedback on the link that we've shared. I think Otieno and I, Dr. Mudoka has already shared. So please just give us some very quick feedback on how better we can improve the coming webinars. We really appreciate your feedback. We really appreciate your support, and have a blessed day. So I want to quickly ask Faith Ndare to close for us with a word of prayer. Faith, kindly, and asanteni sana.
Songok, you said something. Sorry, I didn't hear your last bit.
Sorry, I was kindly requesting if you could close for us with a word of prayer.
Okay, fine. Let's all believe and pray, and thank you so much, everyone. So, our Heavenly Father, we want to bow before your throne of mercy once again this morning. We want to glorify your name for your faithfulness upon each one of us and for making us see this year more, and even for the gift of life that you have accorded to each one of us. Thank you for the deliberations that we have had. They were great deliberations in regards to our work. We commit them into thee, Jehovah God, that you may continue to enable us and give us strength, that for all that we have planned to do, we shall be able to achieve according to your guidance, Jehovah Father. And now as we depart, we pray that you be with each one of us, continue to bless each one of us and our families. And even as the HIV program, as we continue to embark on our work to make sure that we control the pandemic, give us wisdom, give us the knowledge and the strength to be able to serve the people. We thank you and we worship you for giving us a very successful meeting. And it is not because of our strength, but it is because of your presence among us. And we pray with this view, believing and trusting in your only Son, Jesus Christ. Amen.
Amen. Thank you very much, everyone, and enjoy your day. Bye.